So for the folks on the line, my name is Tom Moss. I'm the program supervisor with the Residential Assisted Living Facilities Program. And I'm responsible as a representative of the department to license and conduct surveys at assisted living facilities throughout the state. Today's presentation, I'm going to cover some kind of overview of the program, how we survey, the things we focus on, discharge appeals, just kind of various subjects surrounding our task. So first of all, I wanted to introduce the team. I'm going to try to minimize this. There we go. And kind of share a little bit about us. Like I said, my name's Tom. I'm the program supervisor. We have Donna Kramer, which folks that work in assisted living know her well. She's our technical records specialist, and she primarily works in flares. She communicates with all the providers, family members, administrators, just you know, all the above to keep things on track. On the right side of the screen are all of our surveyors, and I won't introduce each person, but I did want to share that we have different backgrounds. We have about half of the team are registered nurses. We do have social workers on the team. I'm a social worker. We have a couple master level social workers. We have a dietitian. We have some behavior specialists and so forth. So we work together to travel the state and conduct our surveys. We really rely on each other and our expertise and our backgrounds to do a thorough job, protect residents, and treat facilities fairly. And I would just like to say, as I'm going through the presentation, if you have a question, please bring that to Fanny's attention and just interrupt me. I'm happy to answer questions at any time. So the first thing I wanted to cover is what is a residential assisted living facility? And this is right out of the IDAPA rule. That's a facility of residence, however named, licensed in the state of Idaho, operate on either a profit or nonprofit basis for the purpose of providing necessary supervision, personal assistance, meals, and lodging to 3 or more adults not related to the owner. And that definition's very important because we look at throughout the state, there's many independent living facilities, and a lot of these independent facilities look pretty identical to assisted living facilities, and they're not licensed through licensing and certification. And the difference is those independent living facilities, they're not providing supervision, assistance, meals, etc. They're not providing those cares, and assisted living does. There's 3 types that kind of fall under this category. Most of the facilities around the state are just kind of your general assisted living facility. The residents who reside there, they can come and go as they please. The facility conducts a comprehensive assessment prior to their admission, creates a plan referred to as a negotiated service agreement, and the facility is required to follow that negotiated service agreement and meet the residents' needs. People throughout the state who choose to reside in an assisted living facility that's not a memory care are typically not confused, or they're not at risk for wandering and being put in danger. And that's where the memory care type facility comes in. And memory care facilities, I'm going to go into this a little more detail later, but a memory care facility, it's a locked facility, and this and only residents who are confused and have a history or have attempted elopement in their past, etc. You know, they need that secure environment to be safe. That's who resides in a memory care facility or unit. This facility is required to provide a safe and secure interior and exterior environment in a memory care. And we're going to get into the codes and all that stuff later. Another type of assisted living, all this falls under that same rule set, would be what's referred to as a heart home. And that stands for Home for Adult and Residential Treatment. And we've got several of these throughout the state. And heart homes are homes that provide the assisted living care. And then in addition to that, they have a contract with the department, and they're providing additional cares to meet residents' mental health needs. So typically this is a younger population that are residing in these facilities with this additional license contract, if you will, to provide this additional service. That's going to look like group therapy, potentially some medication management, additional supervision, things like that are provided in what are referred to as heart homes. And with that, I'll pause for a second and see if there's any questions about the types of facilities. Okay, hearing none. So I wanted to talk about like who's a typical resident in an assisted living. Who do we typically see when we're out there? So several, just about anybody can reside in an assisted living facility. However, they must be at least 18 years of age. We do have facilities that specialize and they take care of people with intellectual disabilities. Of course, elderly people reside in assisted living facilities, physically disabled, people with mental health needs or traumatic brain injuries. And I just wanted to share that approximately 33% of residents who reside in assisted living facilities throughout the state are reimbursed by, through the Medicaid benefit. And then just about a third of the residents have a diagnosis of dementia. So as Sherry pointed out earlier, we do have rules that we're following and statutes, and everything we do is outlined in IDAPA 160322, which are driven by statute title 39, chapter 33, which is the Residential Care Assisted Living Act. These rules and these statutes are very easy to find, and we very much focus sticking to the rules. Okay, so next, and I'm happy to answer any questions that come up. Next, I wanted to kind of get into, how does licensing and certification ensure health and safety of residents throughout the state who reside in assisted living facilities? So, and this holds true to just about any of the divisions under licensing and certification. So, of course, everybody knows we conduct scheduled visits, regularly scheduled visits. These would be referred to as licensure surveys. They're formally called licensure and follow-up surveys. They're called licensure and follow-up surveys because we're doing a licensure survey and we're following up on previous deficiencies to verify compliance. These regularly scheduled visits are they're unannounced, and with the except for an initial survey. I'm going to talk about that in a little bit as well. We also conduct complaint, or what would be referred to as critical incident investigations. So certainly we get complaints from various folks, residents, of course, family members, staff, visitors, outside agencies. Ombudsman let us know their observations quite a bit. Just whoever's in assisted living facility can call us with a concern or a complaint. And we have a protocol in place on what's formally entered as a complaint, which is basically it's got to be firsthand knowledge and it's got to be an actual rule violation. So we typically do just three activities when we're out conducting our surveys. We've got long protocols, but it really comes down to these three things. So when we enter a facility, we're collecting information. We're collecting that information to verify compliance with rules and to ensure residents who reside there are safe. And the first thing we do is we observe. We observe those residents in their home, and we watch and we verify that their needs are being met and they're living in a safe environment. We talk to them and we ask the residents, we'll ask them, how do you feel about residing here? Do you feel safe? Are your needs being met? Are you receiving the correct medications, etc.? Of course, if a resident would rather not talk to us, we don't push that. We'll just just observe and speak with other residents.
I think we lost the connection.
Just anybody that's involved with that resident at the facility, we try to get a hold of them and ask them how they're feeling about the care that's being provided. The last task, and this is by design, the last task, review. We review the records, and we review the records to verify what we've observed and what we've heard during interviews. We do not look at the records to determine by itself if the facility is compliant or not. We look at all three of those things. I see we have a chat. I'm going to open that. So we've got a question, and the question is, could you define firsthand knowledge of a complaint? And I can do my best. So many times we'll get a call and it's a complaint, and it's from somebody that's never been to the facility, and they didn't watch this concern happen. And so that for sure, right off the get-go, is not firsthand knowledge. That's going from one person to another person and then to us. And when we hear something like that, our response 100% of the time is going to be, we're going to ask that person that's calling us, hey, get in contact with the person that told you this and have them call us, the person that actually saw the event happen or has been to the facility and has this, what we would refer to as firsthand knowledge. You know, they've seen the documents, they've watched the event occur. That's how we look at firsthand knowledge. We don't take complaints when it's going through a series of people and then to us. We need to talk to somebody that actually saw this event happen and has that knowledge to give us the details so we can go in and do a thorough investigation. Does that help, or is there any follow-up questions to that? And just go ahead and speak up if you have another question. I'm happy to answer. Okay, hearing none. I do want to point out here on this slide that we surveyed the regulations. You know, I think, you know, we hear a lot of concerns about some social injustice that may or may not be happening to the resident at the facility or to a family member or somebody involved. And licensing and certification, we stick to 160322. We're one part of a bigger system to protect residents who reside in facilities throughout the state. We'll help people get in contact with the right entity that can help them. For example, I'll just give an example of a concern I heard recently. We received a complaint from a visitor, and the complaint was, I used to visit the facility and they would give me free meals. I'm complaining they don't give me free meals anymore. And while that's a very valid concern, and we recognize that's going to be frustrating for that complainant, we don't have a rule that says that the facility has to provide meals to visitors. So, you know, we might refer that person to speak with the administrator or administration of that facility. We might help them review the admission agreement of that resident. A lot of times it's spelled out in there. They're going to charge X amount for a meal, things like that. We get a lot of those types of concerns to where the concern might be about somebody else other than the resident, or it's just simply not a rule violation. So we stick strictly to the rules as they're spelled out in 160322. Any questions before I move on here? Okay, hearing none. I also wanted to talk a little bit today about, hey, what doesn't licensing and certification do? I think there's some myths out there, and I just want to be very clear on what we do and what we don't do. So the first thing I wanted to clarify is licensing and certification, we do not place residents in facilities or homes. We verify if the facility chooses to admit and retain a resident, we're verifying that they're following the IDAPA rule spelled out in 160322. And that's the long story short is, hey, they can meet their needs. All this resident's needs are being met. They're safe, they're secure, they're getting all the ADL assistance they require, their medications needs are being met, etc. They're compatible with the other residents, those sorts of things. But we will never call a facility and say, you have to admit this resident. That's up to the facility. We're just verifying they're following the rules. And this kind of comes into play too, a lot when a resident is there and maybe they're discharged. And we're verifying the facility's following the rules outlined in the discharge process, which I'm going to talk about in a little bit. We don't say, hey, you have to keep somebody. We can just say, if you discharge them, this is going to be a rule violation. Or, if you keep them, I can cover the rules that we might look at when we're there. So, we don't dictate who they can admit, retain, place residents. That's just not our role. These facilities are all different. They know what they're capable of, and they know who they've already chosen to admit and retain, and they know more than we would ever know their capabilities. One thing we focus on very strictly is we very much avoid giving providers directives outside of a rule or a statute. And in fact, we really rarely give facilities a directive. We would just explain the rules to a facility and help them understand. Hey, you're asking me a question. Let's talk about all the rules surrounding that question, and then they can make their own choices. We don't give these directives. The facility, at the end of the day, they're choosing how they care for residents. Licensing and certification is verifying they're following the IDAPA rules and the statutes. I see a question. Okay, so the question is, to build on that, if you determine that the discharge was indeed a rule violation, what are the repercussions for the facility? And Sherry, if you don't mind, I'm going to table that question for just a minute because I have a few slides on discharges, if that's okay with you. And we can definitely keep that question on the hot burner here to talk about here shortly. So, like I was saying, so we work very hard to not hold providers accountable for issues or concerns that are not required by a rule or statute. We don't decide the rules and the statutes. Our legislators decide that. We're following those rules. Okay. I'll answer that one too right here, Krista. So the question that Krista sent was, where's the line between not being able to care for someone and disability discrimination, such as refusing to accept a deaf resident who needs interpreting services? And so we would partner with Disability Rights of Idaho, other outside entities, to determine if there's discrimination. What we're going to determine from licensing and certification, if a resident is admitted with any need, we're going to determine, can they meet their needs? So do they have an interpreter available? Can the resident, do they have a means to communicate? So those are the determinations that licensing and certification would make. If a resident's abused, neglected, or mistreated, we have tons of rules about that. If they're being discriminated against because of a need that they have, we would most definitely be partnering with other folks to make that determination. It's not a clear line. I mean, there's so many different types of needs out there that residents have. That's a very good question, and that's a tough one. Okay, so as I said earlier, about 2/3, I said about a third of the residents are using Medicaid as the benefit. So that means about 2/3 of residents who reside in assisted living facilities are paying privately. And maybe they're paying, a family member's paying, maybe it's long-term care insurance or whatever that scenario is, they're paying. So licensing and certification, there's nothing in these rules about what those rates are. Our rules would just say, whatever the rate is, the facility's got to be 100% transparent. They've got to break out all the services, exactly what they're going to cost, exactly what the rent's going to cost, and those things. So we don't set the rates. We verify that somebody entering into an agreement like that, it's clear. They know what they're getting into. They know what services are going to cost, and that's got to be in the admission agreement. That's got to be signed before they move into the facility, so it's all 100% transparent. We do see from time to time where maybe it isn't clear and transparent, and that leads to deficiencies, unfortunately. We're not a criminal or justice agency. I've had some facilities use the word charge.
For today, the virtual meeting right now, so I'm listening to.
Stephanie, mute yourself, please.
Yeah, that's okay. It's
So we're not, like I was saying, we're not a criminal or justice agency. I've had providers use the words that I charged them, or the department gave them a charge, or something like that. We don't have badges. We're not police officers. We're surveyors, so we give deficiencies. We don't give citations that you have to deal with down at the courthouse or anything like that. So what we do is we work very hard to partner with other agencies, adult protection, law enforcement, Ombudsman program, et cetera, to help residents be safe. And one thing that we don't do is we don't seek to immediately terminate providers if they fall out of compliance. We've got many rules toward the end of the rule set in the 900s specifically that cover the different types of enforcement action and remedies and the way we can help a facility get back into compliance. We do have the ability to terminate a provider agreement, but it's not what we're seeking to do. These facilities, they are very important for people throughout the state to have somewhere to live. We just want to make sure it's safe and all their needs are going to be met. So, any questions about that slide before I move on? Ready. So, I want to talk about the types of surveys that we do and when we do them. And this is just kind of a general overview of the types of surveys. So I already told you our main focus, our main goal is to do certification surveys, healthcare surveys. We do those annually or every 36 months. And I wanted to clarify how that happens. So if a facility has a survey, we conduct a survey, and they can go 2 surveys and not receive what we would refer to as a core deficiency. And a core deficiency is a systemic issue identified at the facility. Maybe it's inadequate quick care, such as just a complete lack of supervision, or maybe the medications are not being given as ordered to multiple residents. Those types of things turn into what we would refer to as core deficiencies. The facility has to provide a plan of correction. We do a follow-up survey, and we verify that compliance, et cetera. So it's a pretty big deficiency. It's not a good scenario for the residents. So that's core deficiency. If a facility has a core deficiency, they're gonna have to go 2 annual surveys in a row, every 12 months in a row, without another core deficiency, and then they can be put on a survey schedule of at least once every 36 months. So every 3 years. So if a facility is in good compliance, they've not had a core deficiency in 3 years, they'll move to that 36-month certification survey schedule. If they have core deficiencies, recent core deficiencies, we're going to go out there annually and do a full survey. So just wanted to kind of clarify that. Certainly when a facility initially receives their license, we do what we refer to as initial survey. We typically wait about 3 months, and then we go out and we do a full survey. And the goal here is to help that facility get off on the right foot, so we can We can look at their systems. We can talk to the residents. There again, observe, interview, record review, and we're gonna determine what's working well, maybe what's not working well, and we're gonna let them know what that is. That might be through deficiencies, it might be through technical assistance, but we're gonna let them know here's what we're finding to help them be in compliance. We also do what we refer to as follow-up surveys, and this would be the core deficiencies I was just referring to. There's a systemic issue. The facility is going to be required to write a plan of correction. And what this is this is a formal document that says, hey, here's what we're doing to make the repair. Here's the staff we're going to hire, the training we're going to do, here's the observations they're going to do, whatever it is that they have. They're going to do that to say, here's how we're going to repair it. They're going to identify the date it was repaired. And then after 45 to 90 days, we go back and we do another survey and we focus on the deficient practices from before. We verify that it was corrected. That's all that a follow-up survey is. We also do, as I talked about this already a little bit, complaint investigations. So when we do enter a complaint, we try to identify the severity of the complaint to determine how quickly we need to go out there. So it can be 2 days. This is like an imminent danger situation. 60 days, which is pretty much our timeline on any complaint, or it can be 180 days if it's maybe like a documentation issue or something, a residents or there's no fear of the residents being in danger. So those are kind of our timelines on when we go out and actually do an on-site investigation. On rare occasions, we do off-site complaint investigations. This would be for things that don't require observations. The nature of the complaint is such that an observation wouldn't help us make that determination. So, is that a question there?
No, sorry, I didn't mean to unmute my thing.
That's okay. Okay. And then, in addition to that, we also have a fire life safety team, and these are experts in building safety, and they conduct surveys on the same cadence that we would. So if a facility does well, it could be 36 months, or it could be annually if a facility is struggling. They follow the same schedule that we do based on survey outcomes. So of course they'll check things like if the facility has been conducting their evacuation drills accordingly, the fire systems are up to par and meeting codes. They verify all of those issues is in order and the facility's safe. Completely separate process from what the licensure team does. Sam Burbank is the supervisor of that program, and he just does a fantastic job. We're very lucky to have him. So I wanted to kind of go through just a high level. This is kind of what a survey looks like. This is kind of what we're doing when we get to the facility. So, of course, these are on and out surveys, with the exception of an initial survey. We will give a courtesy call, typically the day before on an initial survey. That's in our rules to do that. And we'll do that only if there are no complaints. Many times when there's a change of ownership or something like that, there's a lot of changes happening at the facility, we get complaints. If there's a complaint associated on an initial survey, we don't call. If it's just an initial survey without complaints, we'll give a courtesy call. Especially if it's a brand new facility, because we can ask how many residents are out there. I've gone on an initial survey before after 90 days, and there was 3 residents, I think, in a 16-bed facility. So we wouldn't want to send 3 surveyors out to complete that survey. That would not be responsible. So just there again, high level. Here's what we're up to during survey to determine compliance with rules. So I already said observations, interviews, and record reviews. So first thing we're going to do is we're going to tour the facility. We enter, we find the administrator, we tell them why we're there. There's always at least 2 surveyors on a survey, and we tour the facility. We walk door to door. We speak with residents. We look outside. We verify the structure is safe for residents. We look for maintenance issues, cleanliness, all those things. We do that right off the get-go. And then we observe. We before we crack a book, we complete all of our observations. So we're hopefully going to know everything that's going on with the residents in that facility before we start the record review. And as I said before, we interview anybody that's in that facility, residents, staff, family members, outside services. I mean, just anybody. I've police. I mean, anybody that's been involved in an incident or has anything to do with that resident. We get in contact with them and we talk to them about how things are going. We of course review outside services records. The facility, an assisted living facility, is responsible within the rules to coordinate all services, and that would be to arrange for all the services that are happening in the facility. And as I think everybody here is aware, a lot of outside services come into assisted living facilities, home health, hospice, within that physical therapy, occupational therapy, there's x-rays that come in from outside. I mean, just you name it, speech. I mean, all these entities are coming in, they're outside services, and they're helping the facility support the resident so they can be safe. However, the facility is required to arrange for services. And what that looks like is we've got to coordinate with us outside agency. Let's say it's physical therapy. Maybe somebody's had a few falls, so we're going to get physical therapy involved here to strengthen them so they can avoid future falls. The facility's got to know what the plan is, and incorporate that into their negotiated service agreement. So here's the exercises we're doing. Here's what we're watching for. Here's how you help that person transfer. So those recommendations are going to come from the outside agency. The facility nurse typically is going to take those recommendations, get them incorporated in the NSA, train the staff, all in an effort to meet this resident's needs. So those are very important folks to be speaking with the outside service providers to verify, hey, this is going great. I'm talking to the facility administration, and they're listening, they're incorporating my recommendations. Or unfortunately, we hear sometimes, I don't know who the nurse is. I couldn't tell you who the administrator is. I just come do what I have to do, and then I leave. Nobody's there to talk to. That's a concern, So once we do all of this work, then and only then do we start looking at records. So we pick a sample of residents based on the census at the facility. We're verifying, they were evaluated before they were admitted into the facility as laid out in the rules. They've entered into an admission agreement that's clear and transparent. The facility's completed a comprehensive assessment. They've written a plan, and negotiated service agreement is what it's referred to, on how they're going to meet that resident's needs, and it's all happening. So that's kind of it in a very short nutshell. So we also review staff records. So by this time, we've talked to probably all of the staff. We know that if they feel like they've had adequate training or not. If they've been delegated by the nurse. I mean, they've already told us all this information. So we're going to verify the accuracy of that through looking at the records. Of course, we're gonna verify they've had a background check. They've received the 16 hours of orientation as laid out in the IDAPA rules. They've been delegated by the nurse, all of this stuff, CPR, first aid. We're going to verify all these things are in place, and the facility has those records. So the whole time we've been looking at the environment. The other thing we do is we verify that the facility is following the Idaho Food Code. And we have a rule, it's 450, that says that the facility is going to follow the Idaho Food Code. So we've all been provided training, and we conduct the same inspection that the health department would at a restaurant, for example. We would say, hey, they are following, we go through the whole exact same process as you would at Taco Bell, for example. So we do that whole inspection, use the same exact forms as the health department would, and we inspect the kitchens to verify that they're in compliance with the Idaho Food Code. That's a whole other rule set that can be complicated, and it could be very difficult for facilities to get through that, but that's something that we definitely do. Any questions about that one before I move on? Okay, so just some quick numbers on what's happening throughout the state in assisted living. So currently we have about 273 licensed licenses issued. I should say licenses, not licensed bed. That threw me for a second. There's about 11,500 licensed beds. So we have 367 buildings. And the reason that number is higher is because on some campuses, there's more than one building. There's 3 or 4 or 2, whatever it is, campus or buildings on one campus under the same license. Here's some just quick numbers on where we're at. These are licensure surveys overdue. And this would be, let's say somebody's on a 12-month schedule, if it's 15 months or over, and 34 is the number. That's a really good number. That's as low as it's been in a long time. So we're very proud of that. Same with initial surveys. 33 open complaints. Very proud of that number as well. We enter complaints every week, so that can be a challenge for us to stay up to speed on that. But just very proud of the team for these numbers. So really, it's only been an average of 15 months, 15.8 months since a last licensure survey, and that's averaged across all the facilities. The facilities on the 36-month schedule and the facilities on the 12-month schedule. So we've really done the team, I should say, has really done a great job keeping a very heavy workload to verify these residents are provided safe environments. Okay, any questions about so far I can answer before I continue? I'm going to get in a little bit about the different types of residents who can reside in assisted living specifically, and memory cares. That's my next plan. So secured versus not secured. And I would say that's the question. So we do have a rule, and that rule says that if a facility accepts and retains residents who have cognitive impairment and a history of elopement or attempted elopement, the facility must provide an interior environment and exterior yard that is secured and safe.
Probably only like 15 minutes left, but if you want to,
I can.
anybody else
Do
here
you
who
want me to
wants to
speed this up, you guys?
watch it there, you can watch it there.
Hi, I think Overland Court is trying to get in the facility. Yeah, there you go. They muted.
Okay.
Yeah,
Let me know if I'm going too much. Okay, Fanny?
yeah,
So,
go ahead.
okay. So, and the reason I bring this slide up is there is just a lot of confusion out there on who should be residing in a secured environment. And so I'm going to talk about that a little more. But in general, if there is a resident, they have this history of elopement, they're clearly confused, and they're residing in an assisted living that's not secured, that's a rule violation. Every single year we see residents in that scenario that have unfortunately been put in unsafe scenarios. We've had residents unfortunately leave in the wintertime and they pass away from exposure. Had residents hit by vehicles, just all these things that we're trying to avoid. So that's why this rule, in my mind, is very, very important. So what do we look at when we make this evaluation of if it's secured or not? So number one is it must have fully secured interior. And that's pretty easy for us to evaluate. We tried to get out. We go in, we're here doing our observations and our interviews, and we're looking around and we're evaluating, is this door locked? Can I safely walk out the door? Is anything going to happen? We watch residents. Sometimes we're in a memory care and the residents will literally get up and they'll leave. They'll go outside and they'll be, that's not secured, So they're also required to have a safe and secure exterior environment. There's no rules about what that looks like, other than it's got to be safe and secure. So there again, pretty easy for us to determine. We try to get out. We go out into the yard or the exterior environment. If we walk, and I've done this many times, if you can go out the back door where it's allegedly safe and secure and come back around, somehow get out and come back through the front door, that now that's not safe. So pretty easy to evaluate. We do this every single time we do a survey in a memory care. We ask the residents if they have the code. If a resident has a code in a memory care unit or building, that's not safe. Many times a resident with a code, they'll let another resident out. And I know of at least 2 or 3 scenarios where unfortunately residents have passed away from that very scenario. And I can tell you, interviewing that resident that let the other resident out, that got hit by a car and passed away or ended up in a ditch somewhere, it's gut wrenching for the resident that let him out. So, of course, residents there have to have that cognitive impairment. Now, we do have a caveat here, and I wanted to just bring this to everybody's attention, that the department has the ability to issue variances. And we can issue a variance in this scenario if there's a couple. One resident has this cognitive impairment, they require that safe and secure environment, the other resident does not. We'll issue a variance for the facility. However, that resident, they can't have the code, staff have to let them out because we don't want to be breaking up residents that have been together for years and years, obviously. So what's not secured? So,
Hey, Tom, I have a question real quick before you move on. I
Sure.
put it in the chat, but so is it a violation for the facility staff to give the ombudsman a security code to get in
that's a
and
great
out?
question. Thank you for asking that. Yeah. So we would say in general, it's up to the facility to evaluate who they give the code to. So let's say it's and also they can write their own policies. Some facilities, maybe they've had a bad event in the past and they say, we're not giving the code to anybody. And that's acceptable, right? Some facilities may choose to say, hey, I know this ombudsman, they've been here for years. They clearly get this as a memory care. The likelihood of them leaving that door unlocked is 0. And that's acceptable to give the code to that ombudsman. Just like it would be if you think of a family member. Maybe a family member visits once in a blue moon, and they don't understand what's happening there. They don't understand if they leave that door unlocked, somebody's going to get hurt. You wouldn't want to give that family member the code. However, you got somebody's daughter, they visit every single day. They clearly know what's going on at the facility. You know what I mean? The facility can evaluate that and say, we're comfortable giving this person the code. They clearly know what's going on. They know the residents are going to try to tailgate and leave with them, and they're not going to let that happen. So,
Perfect.
yeah.
Thank you.
You bet. So what's not secured? So must not lock residents in. So when we go to a facility and it's not a memory care and there's a code on the door, that's always going to raise a question. Why is there a code, right? Why are these residents in this facility with a code on the door when it's not a memory care? I'm just kind of saying that's something we watch for very, very closely because that code's there for a reason, so we that's always going to be a red flag. We're always going to try to evaluate, are these residents being locked in? Are these residents confused? Like what's going on that's requiring this code on the door? And a facility that's not secured, they can't admit and retain residents who require that secure environment. This is going to lead to very bad outcomes potentially for the residents. So residents who are oriented and can freely come and go and find their way back home, those residents are who you see in a typical assisted living that are deemed not secured, non-secured. However, just want to bring this up. Residents who have cognitive impairments but cannot leave due to physical abilities, have not attempted to elope, and they're compatible with the other residents, it's not a rule violation if they're living in an assisted living facility that's not a memory care. I think there's many examples of this throughout the state where a resident, maybe they age, they're physically not able to leave, they're safe, but then confusion comes in toward the end. That's totally acceptable. The resident doesn't have to move into a memory care if the facility can meet their needs. Okay. So I want to talk just kind of, we're getting down there. Thanks for hanging in there, you guys. So I wanted to talk kind of just in general, what the facility is responsible for and kind of how they identify themselves. So we do have rules under 152 in our rules. And again, these are all under 160322. These rules would say that the facility must develop and implement policies which include the purpose, quantity, and characteristics of available services. So they've got to have a policy that says, here's who we can help. This is what we do here at this facility. You know, we're a memory care, we're not a memory care. Maybe it's a heart home. They're focusing on helping folks with mental health needs, whatever it is that facility is doing, they've got a policy that kind of outlines that as a goal. And most of them do. They do a really good job at this. And then I wanted to talk more about who by rule they can legally admit and retain. So a facility can only admit and retain a resident when the facility has the capability, capacity, and services to provide appropriate care. So a facility cannot admit and retain somebody when they just can't meet their needs, is what that comes down to. And I think this is frustrating for people in general, because maybe a facility's admitted this type of person before, or somebody with similar needs in the past, but maybe they can't now. Maybe they just don't have the staff, or they don't have the trained staff to meet their needs, or maybe they already have 2 or 3 residents which are requiring a lot of supervision. Maybe they just don't have that threshold to just, admit more with those high level needs. So it's really up to the facility to do those evaluations and those determinations. Next, the facility, does not require, the resident does not require a type of service for which the facility is not licensed, or for which the facility does not provide or arrange for. So they're again already said the facility is responsible to arrange for all the services in the facility. In a facility, I'm going to go through a little laundry list here in a minute of the rules, which would say, hey, you simply don't have a license to do this. And the long story short is they don't have a license to provide skilled nursing level of care. That's a skilled nursing license. And then they can only admit and retain when the facility has the personnel appropriate in numbers and with appropriate knowledge and skills to provide the services. So for example, some facilities have a very robust nursing plan. They have nurses there every day. They have an RN, they have LPNs, and that's their plan. That's what they've chosen to do. And they admit and they retain residents that might have a higher acuity level. Some facilities have minimal nursing oversight. And that's okay. The facility is going to make that determination. Hey, we're not going to admit residents that require nursing services on a daily basis, for example, up to the facility.
Hey, Tom, we're at 5 minutes.
Okay.
So if you want to,
I can wrap this up. 5 minutes. I got it.
Thanks.
Is that definition the same in skilled nursing? I don't know what the definition is in skilled nursing, to be honest with you. So I don't know if I want to answer that precisely. But in general, in assisted living, if you require that skilled nursing level of care and actually have to have a nurse there to meet your needs, then you wouldn't be in the right plan, right type of facility. Okay, so here's a quick list for earlier it came up. There was a question about discharge notices. I think the question was along the lines of, okay, if you determine that the discharge was indeed a rule violation, what are the repercussions for the facility? And really the only repercussions from licensing and certification are deficiencies. So when we identify that a facility violated a rule, we give a deficiency, and then we make a determination on that deficiency. Is this a systemic issue, or is this just a one-time issue? And that would help us determine, is this a non-core or a core deficiency? But that's from licensing and certification standpoint. That's from my seat. I can just give deficiencies. I can also give enforcement actions if there's a pattern. So what's the responsibility during a resident discharge? So of course, in our rules under 217, I won't go through these line by line here in the spirit of time, but there's a list of things, they've got to have a discharge notice and the resident needs to be informed of certain things. The reason for the discharge, the rule by the potential, the reason they can't meet their needs. We're going to make sure they have the number to the local ombudsman. We're going to make sure that they have the number to other advocates and so forth. Probably the last slide I'll go over here. It's very important for the department and for licensing and certification to partner. And we do want to collaborate with other entities to meet the needs of residents. So just yesterday, Fanny and I, for example, we sat through the Community Care Advisory Council meeting. We do that. We do consultation available, and this is by rule, we're to do this. We do this in the office or we do it by phone. So if a facility has a question about the rules, we have a surveyor available 8 to 5, Monday through Friday. And we answer those questions. And we don't say, hey, if you do this, we're coming out, we're going to give you deficiency. We simply explain the rules. And the facilities they choose on their own how they're going to proceed. We collaborate with the Idaho Healthcare Association. We do trainings throughout the state. We do what we call boot camps and regional one-to-one training with struggling providers. We're able to give technical assistance before a deficiency if we feel like that's more helpful. And of course, facilities have the right to appeal our findings. And I wanted to put up our information and just clarify that that number there, 3641962, Monday through Friday, 8 to 5. We have a surveyor available. We're happy to answer questions related to the RALPH program.
So this concludes our program for this month. We hope you enjoyed it and found it valuable, and we look forward to seeing you again next month. Next month, we're gonna have Tiffany Robb. She's from the health program. She's a health program manager for the Division of Public Health, and she's gonna be talking to us about Alzheimer's and dementia care and long-term care. So thank you again, Tom, and everybody have a good night.
Thank you. Thank you, Tom.